Children who might be candidates for enteral feedings during transplantation include the following: those with a functional GI tract, those receiving a non-myeloablative or reduced intensity conditioning regimen because they tend to have less risk of regimen-related toxicities, those undergoing low-risk transplants such as an autologous or a matched sibling transplant who again have a lower risk of developing graft versus host disease, children with chronic graft versus host disease who need long-term nutrition support, especially those with oral or esophageal problems, and children who are critically ill requiring ventilation are other good candidates. Enteral feedings tend to be better tolerated when initiated slowly with a continuous infusion and then gradually increase at the rate as desired. Well, while there's many benefits to enteral feeds, there have been several complications reported in the transplant literature regarding the use of feeds during transplantation. We've seen reports certainly of dislodgement of nasoenteral tubes where the child just hasn't tolerated the tube and ends up vomiting the tube. There have been reports of delayed gastric emptying or gastroparesis. And finally, inadequate energy intake because of suboptimal support, which then resulted in weight loss, decreased body cell mass, and inadequate mineral and electrolyte intake. Well, if we can't feed the child through the oral route or enteral feeds, parenteral nutrition is certainly an important component of the overall treatment plan and still remains a standard supportive care. Parenteral nutrition is usually initiated in the conditioning phase, as most children have decreased intake or stop eating due to nausea and vomiting. Some indications for the use of TPN during transplantation include the following: children who are undergoing a myeloablative conditioning regimen with severe GI toxicity, children who develop moderate to severe gut GVH accompanied by poor oral intake, and children who have suboptimal nutrition support from the enteral route. And it's important to individualize the child's macronutrient composition of the parenteral nutrition solution based on their medical status. Well, there have been lots of interest regarding the use of glutamine supplementation, either in parenteral nutrition formulas or the oral route, and many studies have been published over the past decade. A recent analysis by Crowther and colleagues examined the use of glutamine in a review of 17 randomized controlled trials, and they found the following: that glutamine supplementation during transplantation may reduce mucositis, days of opioids, graft versus host disease, clinical infections, and positive cultures. Glutamine, however, may also increase the risk of disease relapse, and this was shown in 2 small studies using IV glutamine. They mentioned that overall there's no real effect of oral or IV glutamine on transplant-related mortality to day 100. And in summary, larger, well-designed studies really are needed to confirm the beneficial or adverse effects of glutamine supplementation. So for now, I don't think we can really recommend routine use of glutamine supplementation until further studies are done. Well, we've now talked about nutrition assessment, determining nutrient requirements, and methods of nutrition support. And I want to move on now and address some of the common complications that we see in children undergoing transplantation. Working in oncology, we're all very familiar with the multiple oral and GI manifestations that occur as a result of the disease and treatment. Mucositis, nausea, vomiting, anorexia, diarrhea are very common problems. A problem very unique to transplantation, however, is that of graft versus host disease, or GVH. And despite advances in management, GVH remains a significant problem and a major complication of allogeneic transplantation because of the expanding use of unrelated donors and partially histocompatible related donors. By definition, GVH is a T-cell-mediated immunologic reaction of engrafted lymphoid cells against the host tissues. It typically occurs in the first 100 days post-transplant, with the incidence anywhere from 35 to 85%, depending on the type of donor. The target organs affected include the skin, the liver, and the GI tract. Common medications used to prevent and treat GVH are shown in this slide, and frequently multi-drug regimens are necessary to manage GVH, resulting in profound and prolonged immunosuppression. Most therapies have many nutritional implications which need to be closely monitored. And over the years, the mainstay of treatment has historically been corticosteroids with prednisone, which, as you can see, has many, many nutrition side effects. Provision of adequate nutrition support is a vital adjunct to immunosuppressive therapy in the treatment of GVH. And in severe cases, nutrition management typically includes bowel rest with full TPN support. Once these are ready to be introduced, bland, low-fat, low-fiber solids and isotonic liquids can be instituted, and then the diet can be expanded as tolerated. I think it's important to remember, though, that because the clinical manifestations of GVH vary so greatly, no single progression pattern can really be described. Also unique to transplantation, we have the problem of chronic graft versus host disease, which typically presents after day 80 post-transplant. There's also an increased frequency in transplants from non-identical and unrelated donors, and the incidence varies from 30 to as high as 60%. Nutrition problems associated with chronic GVH reported at 1 year post-transplant may include weight loss, weight gain, oral sensitivity, and oral dryness. And while this study by Lenson and colleagues was published back in 1990, we still see many of these nutrition issues in our patient population today. Osteoporosis is another well-documented problem in our long-term patients. Corticosteroids, including prednisone, are frequently used in the treatment of graft versus host disease and are associated with trabecular bone loss and decreased bone formation. There have been several reports of decreased bone mineral density leading to osteopenia and osteoporosis in pediatric patients. So calcium and vitamin D supplementation as well as weight-bearing exercise are recommended. And finally, bisphosphonate therapy, such as pamidronate, has also been effective in improving bone mineral density in this population. Growth and development issues are also very frequent in the transplant population. We've seen reports of compromised growth and development, including growth hormone deficiency, delayed growth velocity, and delayed onset of puberty. And it's really important to assess these children annually for their growth and development, as well as any endocrine dysfunction, especially when they're discharged from the transplant center, because oftentimes appropriate hormonal therapy may help to improve their growth and development. Finally, in the transplant population, we see problems with endocrine dysfunction. There's been alterations in lipid metabolism secondary to many of the immunosuppressive medications and organ dysfunction. Pancreatic insufficiency due to chronic graft versus host disease has also been observed. And children with pancreatic insufficiency tend to do very well with pancreatic enzyme therapy replacement. There have also been reports of insulin resistance, hyperglycemia, as well as diabetes in this population. And finally, we recently completed a retrospective review of a group of long-term survivors transplanted for childhood ALL and found that patients were at risk for the development of metabolic syndrome, as evidenced by presence of obesity, hyperlipidemia, and hypertension. In summary, hematopoietic stem cell transplantation is an accepted therapeutic modality for a variety of childhood malignancies and disorders. The treatment is aggressive, resulting in multiple acute and long-term nutritional sequelae. Survival rates vary and depend on the diagnosis, the stage of the disease, and donor source. However, more children are surviving as a result of the improved knowledge and skills of the transplant team and improved supportive care measures, including nutrition support. Thank you for your attention.